Good mornings. I know some people are coming from other parts of the world, so muchas gracias. Thank you very much for this webinar. Thank you, AJL, for this interesting lecture. I'm not really expecting a big audience because this is a very specialized technique. So let's get on with this. So if you are in this webinar, it's because you have interest in giving your difficult cases more options. And we know that the general indications for keratoprosthesis surgery would be high risk for graft rejection. This is done actually in bilateral cases or only eyes. We don't want it in an eye that is the other eye is seeing. So this is really for end stage cases. And these would be the patients with limbal stem cell deficiency, whether congenital or acquired, aniridia, Stevens-Johnson, mucous membrane pemphigoid, severe chemical burns, or multiple surgery, Sjogren's syndrome, or any disease with severe corneal neovascularization affecting almost all the quadrants. And this is when you would consider it, when you have done all other procedures like SLET or COMET or KLAL, etc., that you've done practically all the conventional corneal surgeries and it has failed. And why do we consider keratoprosthesis surgery? Because we know that the success rate for succeeding penetrating graft is goes down like a roller coaster. So it's 25% at 5 years with a second graft and 0 at 5 years with a third graft. So why would you do another penetrating graft if you know it will be failed? And that has been shown with statistics. So before we proceed with the surgical technique, I want you to understand why it's important to know what keratoprosthesis you are using. So acrylic is the ideal material for the optical part, as it is lighter than glass. It is highly resistant to stress and strain and can be molded to different shapes and sizes. So keratoprosthesis can be classified depending on the haptic material. It could be biological, it could be autologous, Osteo-Odonto-Keratoprosthesis using canine tooth. It could be with tibia. It could also be, aside from being biological, it could be biocompatible, just like the very known Boston KPro, Cardona's KPro, Pintucci's Dacron KPro, the Alpha Core, the Keraclear, the Endo KPro, which is also a product of AJL, the microcornea, the cornete, or the Mio keratoprosthesis, which have been implanted in different parts of the world. As I've said, you can study your keratoprosthesis depending on the material. Now, we should understand the keratoprosthesis depending on its fixation type. You can either have a transcorneal device, just like the Boston KPro, where you have the back part inside the eye, and it goes through and through the cornea. You have the donor cornea, have the back plate, and then the front plate. It could be intracorneal, and it could be just epicorneal on top of the cornea. So why is this important? Because this can determine the kind of complications that you have with the keratoprosthesis surgery. So the more material that you have inside the eye, the more likely that you will have complications, as I can show you later. So my clinical background, I've been doing Boston KPro type 1 since 2009. I've done a couple of cases of type 2, which is transfebral in 2016. And I've been doing OOKP and Tibial KPro for the past few years, and I've been trained under the late Dr. Jose Temprano since 2012 at the Clinica Barraquer. And I have observed with several mentors in Spain, in the UK, and India. So if there is one slide or two slides that I would like you to really remember, is this one, the importance of clinical diagnosis. The diagnosis is a significant determining factor for the success of your KPro surgery. And if you haven't read the article in Cornea 2015, I think it's very important if you want to go into the world of keratoprosthesis, as it gives you the suggested guidelines in reporting keratoprosthesis results. And it's a consensus of different cornea societies around the world. So we simplify our classification of diagnosis basically into 3. And think of it as your stoplight, como un semáforo. Autoimmune cases like Stevens-Johnson, pemphigoid, Murren's ulcer, or Sjogren are high-risk cases. Whatever kind of keratoprosthesis you put, it's high risk. Chemical burns are intermediate risk, and non-autoimmune corneal opacity, like repeated graft failure, silicone oil keratopathy, limbal stem cell deficiency, herpetic keratitis are low risk. And this is another important slide that I want you to carry home with you, to study your ocular surface unit. Now that you know your diagnosis, now you have to know what kind of eye you are dealing with. Is it a wet blinking eye where you have a complete blink, no keratin, complete lid closure, and your inflammation is under control? That is a very important phrase, inflammation under control. So if you have all of that, then you can probably think of doing your Boston KPro type 1, or your KeraClear, or your Endo KPro, or Cornete. The last three don't have too much of follow-up yet, but Boston KPro is, and as you will see, the gold standard for now. Or are you dealing with a dry, non-blinking eye? And we will go to that later. So, wet blinking eye. We know that the Boston KPro from Massachusetts is the present winner for all the keratoprosthesis because it is very easy to use, and it has actually been implanted in all parts of the world, in all corners of the world, including the Philippines, where I am from. So the surgery is straightforward for any surgeon who has done a penetrating corneal graft. It's been there since the 1960s, approved in Europe in 2013. It has a PMMA optical cylinder. The model that we have in Europe has a titanium haptic. It was classically indicated for cases of repeated graft failure, but now the indications have been extended to cases like chemical burns. You usually need a donor cornea because you want a healthy cornea to hold that prosthesis. It is a penetrating procedure. It has an aphakic and a pseudophakic model, and it has a backplate with two sizes, 8.5 and 7 millimeters. So any cornea surgeon can actually do this technique, and you have your prosthesis mounted in less than 5 minutes. So let me share one of the first few cases that I did. If you look at picture A, up on the left, you can see that it's a wet blinking eye. So I was just a beginning cornea keratoprosthesis surgeon back then. It's a Stevens-Johnson male, 51-year-old, living abroad. He had a kidney transplant due to renal failure, and he was immune suppressed. And you follow the pictures, picture B and C, D, E, F, G, and H, you can see that this patient has had several complications. But he had a very good vision of until 0.6 and enough to be able to drive. However, this patient had poor hygiene and he wasn't very able to come back to Barcelona for follow-up. So he had repeated infections. I had to do like 5 Boston KPro exchanges, and unfortunately, glaucoma left him without vision. But the prosthesis is still in his eye. So I've learned so much from this case. So what are the complications of your Boston KPro? You have the retroprosthetic membrane, you have glaucoma, you have posterior segment complications. And this is quite frequent because of the amount of foreign tissue that you have inside the eye. So you have infection and you have corneal melts, especially in high-risk cases. So I would like to stress that your diagnosis is very important to determine the success of your KPro surgery. So what are the advantages and disadvantages of the Boston KPro Type 1? It has a wider visual field, it is aesthetically acceptable, it is reversible, it is easily repeatable, as I have shown. However, it has its cost, it is custom made, and it has a higher incidence of complications, as my team and I were able to show in this publication in Ocular Surface in 2019, where we compared clinically comparable cases of chemical burn and autoimmune disease using the osteodonto, the tibial bone, and the Boston keratoprosthesis. And we were able to show that Boston KPro had higher incidences of complications in these cases. So now let's go to the dry non-blinking eye, where you have severe fibrosis of the ocular surface, where you have symblepharon, ankyloblepharon, keratinization, severe dry eye, and poor eyelid closure, as we can see in the pictures at the bottom right. So for these cases, you would probably want to do your modified Osteo-Odonto-Keratoprosthesis, originally developed by Strampelli, and then through the years, it was modified by Falcinelli. Then you can also do your Tibia KPro, which is developed by Temprano in Barcelona. You can also do your Boston KPro Type 2, which is transpalpebral, and the Pintucci Dacron KPro. So, dry non-blinking eye. If you haven't read this article by Sharma and et al., it is a very interesting and nice article which summarizes the different keratoprosthesis that you have at hand for cases with dry eye. And this diagram simplifies how you can actually decide on what material to use if you know that your patient requires an OOKP. The gold standard is still the tooth, as you can see here. And that has been shown by several publications by myself and by a team from India and by the team from the UK, which are and also from Italy. So if you have a suitable canine, please go ahead and do your OOKP. But if you don't have one, then you have your options at the bottom. So today I will be presenting the case of a Tibial KPro, and then on the sides you can see that there are other options. But what I want to present today is the technique of the Tibial KPro. So this is me in Barcelona, in Oftalvis in Barcelona, doing the Tibia KPro surgery on this male patient, 63 years old, who had Stevens-Johnson, had multiple amniotic membrane implants. Due to a corneal perforation, you can see that this patient has ankyloblepharon. I had to put sutures, traction sutures on the lid because I could not obviously insert the speculum. I did the peritomy until I was able to insert the speculum. This is a very bloody surgery, so if you don't like blood, I don't think this kind of surgery is for you. Then I isolate the 4 recti muscles using silk sutures. This is very important for anatomical landmarks and to move the eye around when you implant the oral mucosa. Then I proceed with a keratectomy. Underneath, you can probably see that the cornea seems to be clear. However, this patient had several perforations, so my decision was to change this cornea. And here I am taking out patient's cornea because I don't think it will be strong enough to hold up with a keratoprosthesis on top. In Barcelona, we have changed our protocol, so we do the removal of the cataract. At this stage, I put a temporary keratoprosthesis of Eckerd. My retina colleague does a wide vitrectomy and does an internal limiting membrane peel. It is very important to do these procedures at this stage because you have much better visibility. And if in the future you need to do or implant a valve, then you already have done your wide vitrectomy. So here I'm putting a donor cornea. I'm taking out all the epithelium. Then I harvest the oral mucosa from the inner cheek. I take out the excess fat globules and the muscle. I take it from the inner cheek because it has a thicker substantia propria. Then I fixate the mucosa onto the scleral bed with 4 main sutures right in front of the insertion of the recti muscles, which will help in the vascularization of the mucosa. These are, I'm using here the Bikel 7.0 sutures. It's important that you do not tense it up too much, nor is it too loose. So if the patient has a tooth, you can use your canine tooth. But this patient did not have good tooth, so I used the tibia. This is a customized refine. And I'm using a motor to clean up the rough surfaces of the spongy side of the bone. So you have the cortical part and the spongy part. Then I'm using diamond burrs to create a hole in the center, much like a donut. Different sizes, and here I am implanting the AJL lens. I am using dental cement to fix it, taking out some of the excess. And you can see the excellent optics of the lens. So once you are sure that your lens is stable with the lamina, then you implant it in the inferior orbital pocket. We're making a skin incision. And it will stay in this, in the inferior orbital pocket for 3 months for it to get vascularized. Then I close it by layers. And then now I'm showing you a picture of the oral mucosa whose color changes as the weeks pass by. And this is the color that you want. You want it pinkish and vascularized. So now that my mucosa is good and the 3 months have passed, I am opening up again the lid, the inferior orbital pocket, and you can see that the lens is underneath. I dissect it out carefully by palpation. As you can see, it is bloody, so I palpate and make sure I get the maximum amount of fibrotic tissue around the tibial piece. You can see that it has 2 sides. It has one side with a wider diameter and one side with smaller diameter. This is the side that goes inside the eye. So you have to clean out the optical axis and excess tissue in the inner part of the piece that goes onto the ocular, on top of the sclera. Being very careful not to damage the lens. And this is the external part of the piece, which has a smaller diameter. And here I want as much tissue, fibrotic tissue as I have. So once I'm assured that my piece, my OOKP or tibial piece is good, then I proceed with the lifting up of the mucosa, 270 degrees. Then before I open up the cornea, I'm placing here 3 pre-placed sutures, which will facilitate or help me in implanting the lens. So I am not in open sky so much of a time, because remember, this eye is a phakic. So now I proceed with the trephination. This is a 5mm trephine, so that the optical cylinder can go in and fit snugly, and I do not have to put or make any relaxing sutures. So it fits snugly, and then I know that I will not lose any of the liquid inside the eye. Remember, this case is a phakic, so with the pre-placed sutures, it is much easier for me to fixate the piece on top of the sclera. So I just pull out the pre-placed suture and voila, it's fixed. It doesn't move right or left because it's very stable. It's very stable, especially when the size of the lens and the size of your trephination are snugly fit. So I put several more sutures and make sure that the axis of your cylinder is perpendicular to the macula. Otherwise, your patient will have poor vision and a very narrow visual field. Here I am using Vicryl 80 sutures. So once I am sure that everything is in place, then I close up the mucosa. Here I'm using Vicryl 70 sutures. Trying to evenly distribute the mucosa as much as I can. Here I'm finishing the suturing of the mucosa. And then by palpation, I do the trephination of the oral mucosa using a 3.5mm trephine. Careful not to damage the optical cylinder underneath. And I complete this procedure, this step, using Vanna scissors. So surgery is now completed. And these are the OCT of the anterior segment images. This is a picture of the eye. And this is a bonus video of my patient. So you can see, you can imagine his visual field is actually wide because he can do this kind of work. This patient actually loves gardening, and he has been blind for the past 4 years. And for me to see him do what he's doing in this video, just like really, well, you know, if you can change lives, then why not? Patient is from Portugal. So, yes, surgery is quite complicated, but complications are also a factor that would say, I don't want to do this, no? But then again, you have to know how to deal with it and diagnose it as soon as possible. So complications could be mucosa related. You can have necrosis, and you can have overgrowth. You can have extrusion, and extrusion is mostly if your mucosa is not good. Then you can have bone resorption, which is more common in females. You can actually quantify the amount of bone resorption using a cone beam CT scan. You can have infection, although it is not as common as you have in the Boston KPro. You can have glaucoma, and again, it's not as common as you have in the Boston KPro. Then you can have your posterior segment complications like retinal detachment, cystoid macular edema, and vitritis. And it seems like with the change in the protocol that we are doing, where we do the wide vitrectomy and peeling of the internal limiting membrane in the first stage of surgery, I think we are bringing down the incidence of posterior segment complications in these cases. So early diagnosis and treatment are key to prevent the loss of the eye anatomically and functionally. So what are the advantages and disadvantages of your OOKP and Tibial KPro? First, it is autologous tissue, so you have less chances of the eye giving such an inflammatory reaction. And as being that, you have less complications than the Boston KPro. Immune suppression is not mandatory, although if the patient is young and it has an autoimmune disease, I prefer that the patient be immune suppressed. Learning curve is very steep since cases are few. Glaucoma and retina surgery are possible in the hands of an experienced surgeons if you already have an osteodonto or Tibial KPro in place, and then you have retinal detachment or you have glaucoma. Yes, surgeries can be done, but you need an experienced cornea because remember that the optical cylinder has its length. It is about 9 millimeters, and visibility is quite hard for a retina surgeon who does not have experience with this. Aesthetics is an issue, although a prosthetic shell can be placed. And as I said, this visual field is smaller. It is hardly reversible. It is difficult to repeat and achieve the same results. Although I just did one case which had extrusion, I had to repeat everything, and the patient has actually achieved the same visual results. So very happy so far. And it's a Stevens-Johnson case. So I just wanted to share this case with you, which I presented for my thesis for the Royal Academy of Surgeons in Catalonia. This patient had severe bilateral chemical burn. On the left hand of the screen, an OOKP was done in 1987. So you can see the diameter of the cylinder. This piece is still in place up to present. The patient had good vision in this eye, but he wasn't very comfortable with the vision because he had a high hyperopia. So he requested for surgery, an option for his left eye. And since it was a wet blinking eye, then we did a Boston keratoprosthesis. And you can see the OCT images comparing the width of the optical cylinder. So this patient sees preferentially with the eye with the Boston KPro. So with the improvements in the design of the cylinder, now we can see we can achieve actually a wider visual field with the cylinder of the Osteo-Odonto-Keratoprosthesis. So this ends my lecture. My take-home message for those who are here, whom I know are very interested in giving their patients better options, first you study your enemy. What is your primary diagnosis? Because diagnosis is key to success or to failure. Know what you're dealing with. Is it a wet blinking eye? Probably you would choose a Boston KPro. Or if it is a dry non-blinking eye, then you would probably choose your Osteo-Odonto-Keratoprosthesis or your Tibial KPro. Know what your tools are. Ask help from other soldiers who have experience. And get ready with a battle plan because it could be bloody. So this is where I work. I'm in Barcelona. And if you're interested in learning, we have this master course in advanced ophthalmic surgical techniques with the Universitat Abat Oliva in Barcelona. If you want to, if you're interested in this program, then you can write me an email or check me out on social media. And this slide is dedicated to my mentors, Professor Joaquin Baraquer, Dr. Temprano, Dr. Falcinelli, and Dr. Dolman, who have inspired me through the years. Thank you so much.